So benzodiazepines, the antidote here is flumazenil or romazicon. Think about this as being the Narcan, but for benzodiazepines. Why do we not use it? Why do we not carry it? Because if you end up giving the medication, you may end up actually causing some seizure activity to develop, and we don't want that to happen. So it's an untoward effect, and really the side effects of the medication can be worse than what the overdose is. So with your benzodiazepines, if you recall, really the thing that we need to be worrying about is really airway and respiratory efforts. So if we can make sure that their airway is protected and that they're able to ventilate appropriately, there's really no reason to administer the flumazenil or romazicon, because the benzodiazepine will eventually wear off. With beta blockers, we can think about glucagon, and that's 3 milligrams IV push. That's kind of what you start at as far as your beta blockers. Calcium channel blockers, if you have somebody that has taken a calcium channel blocker, they're blocking the ability for the calcium channels to do what they're supposed to do. The antidote here is going to be calcium. And I know that now calcium chloride, calcium gluconate are being carried. So if you have a calcium channel blocker overdose, calcium would be the antidote, or what you should be thinking about giving. And it is 1 gram IV push. For cyanide poisoning, hydroxycobalamin is the new. This is your treatment if somebody has been pulled from a fire and you think that they have any type of cyanide poisoning. The old system was amyl nitrate, sodium nitrite, and sodium thiosulfate. We've gotten away from that as much as we can, because if they are not cyanide poisoned, then by giving that 3-drug combination, we basically prevented them from being able to carry oxygen. By giving hydroxycobalamin, it's vitamin B12. And if any of you are drinking an energy drink, I say this every time I do this talk, look at the back of your energy drink, your Monster or whatever it is that you're drinking, and you will find that it contains cyanocobalamin, which is again, vitamin B12. So in that situation, if they are cyanide poisoned, we have saved their life. If they're not cyanide poisoned, then we have just given them a really, really hefty dose of vitamin B12, and it won't cause any long-term effects. With your opioids, we're thinking Narcan. Everyone's familiar with that at this point. Tricyclic antidepressants. So the two that are really big are your amitriptyline and Elavil. And from a testing procedure, this is a national registry test question. It is a national registry hands-on scenario. If you're doing your hands-on and you're integrated out of hospital patient encounter, you're going to be probably presented with an amitriptyline or an Elavil overdose. And the antidote here is sodium bicarbonate. We give 1 amp or 50 milliequivalents. It's 1 milliequivalent per kilo. That is the standard dose of sodium bicarbonate across the board. And how will we know to do that? It's when your QRS starts to widen out. So if they give you a situation that says you have a patient that has a tricyclic antidepressant overdose, or they'll use one of these by name, amitriptyline or Elavil, and you notice that the QRS is starting to widen out, what would be your appropriate treatment? The answer is the administration of sodium bicarbonate. For dystonia or dystonic reactions, if it has been caused by Haldol or Phenergan, the treatment here is 25 to 50 milligrams of Benadryl or diphenhydramine. Specific ingested poisons, we talk about acids and alkalis and which one is worse. So really the alkali is the one that is worse. So the reason for that, acids, excuse me, with acid burns, you end up getting what is called a coagulative necrosis. So you start to actually kind of form a skin scar, if you will, and it prevents further penetration of whatever the acid is down into deeper tissue. In your alkali burns, you don't get a coagulative necrosis, you get a liquefactive necrosis. And what happens with your liquefactive necrosis is you don't get that scarring formation. So whatever the alkali is able to penetrate deeper into the skin, and it causes a deeper, more severe burn. Dilution, you can either do that with milk or water, 200 to 300 mLs. Most of us are probably going to use water because it's in abundance. Laundry detergent pods, There were 10,000 exposures in a 10-month period in 2017. Interestingly enough, my wife happens to work for one of the big consumer products companies in Cincinnati, and her boss actually had to testify in front of Congress because of this situation. And they kind of got a bad rap, but the reality was it wasn't necessarily the brand name. Certainly they may have been responsible for some of them, but there's knockoffs and people would eat them, and then the kids would eat them because they look like candy, and you probably remember that many years ago. But it would always get referred back to what the brand name was, right? So what we're going to do in these situations and with all poisonings, the solution to pollution is dilution. So wash off the skin in copious amounts of irrigation. If it's a hydrocarbon poisoning, there's really not a pre-hospital treatment that is available. With methanol, we want to make sure that we don't give any type of activated charcoal. In fact, in today's world, we should not be even carrying it. A couple years back, K-beams did require it, and you actually had to have a waiver to not carry it. So I would submit a waiver every year saying we do not want to carry it. And then ultimately, K-beams caught on, and they said, oh, okay, well, nobody should be carrying it. So now you're not allowed to carry it. And if you want to, you have to have a waiver in order to carry it. Poisonings kind of continued here. Ethylene glycol, antifreeze or windshield fluid, thiamine can be administered to degrade the glycolic acid to what are non-toxic metabolites. So if you have thiamine, which is again a vitamin, you guys probably learned when you were talking about Korsakoffs and Wernicke's in paramedic school, but it basically breaks down the glycolic acid into things that your body is able to utilize and metabolize, and it doesn't really cause a lot of problems. They may end up having seizure activity, and we can give benzodiazepines for that. Isopropanol, no pre-hospital treatment is known at this time. Metals, there are different metals out there. Iron and lead are the most common. Not a lot that we're going to be able to do for that. Mercury, if it is a mercury exposure, then dialysis is the treatment, in which case we need to have rapid transport. You can see again your tricyclic antidepressants, severe hypotension and cardiac arrhythmias, the wide QRS complexes, and the antidote, once again, the sodium bicarb. And that is on there 2 different times because it is very, very important that you guys end up getting that if you are to happen to see that in testing. And certainly if you see it in reality, we should be thinking about administration of sodium bicarb. Your cholinergics, you guys are probably more familiar with your anticholinergics. Your anticholinergic, the one that would come to mind most commonly is going to be atropine. That's your anticholinergic. And if you think about why we would give an anticholinergic, it's for this, right? Cholinergic poisonings. And you guys probably remember sludge or sludgum. There's different things out there, and we have both muscarinic and nicotinic effects. But your pesticides, your organophosphates, and your carbamates will cause cholinergic overdose. Your nerve agents like sarin and soman are another one that will do that, in which case you can see there the salivation, lacrimation, urination, defecation, GI upset, and then emesis. So everything starts to basically escape the body. So how do we treat it? We give an anticholinergic to help dry them up. And that is why if we have a patient that we think has been exposed to an organophosphate, the drug of choice is going to end up being atropine, not necessarily your 1 milligram, but many, many, many milligrams, like a couple 100 milligrams is what you're going to need to give. So the reality is you don't carry enough. You're going to end up having to contact the hospital, and they're going to have to pull all the atropine that they can so that you can hopefully reverse the effects of your cholinergic overdose. Just interestingly enough, one other medication, when I said anticholinergic, maybe some of you were thinking about atropine. There is another anticholinergic that we carry. And that medication is the ipratropium. So when we're talking about Duoneb, we give them albuterol and ipratropium. And if you think about why we would do that, your albuterol is your beta-2 agonist. It's going to open the airway and allow for better gas or better ability for the patient to get gas in and out. But why would we give the ipratropium? Well, remember, with ipratropium, it is an anticholinergic medication, so it is going to dry secretions. And if you think about it, when we're talking about a patient that is a chronic bronchitis patient, those goblet cells have an increase in mucus production. And because of that, we're getting a lot of phlegm and we're getting a lot of mucus, and we're trying to dry that up as best we can. So how would you give that? You would obviously give it as a duoneb with both your albuterol and ipratropium. Cholinergic treatment here, your ABCs, decontaminate the patient. Think about atropine, 1 milligram IV push every 3 to 5 minutes. And as I said, you're going to have to keep giving it over and over and over. And then the other medication with this duodot is a medication called pralidoxine. And this actually comes as a duodot. So there are 2 different medications. You have your atropine here and you have your pralidoxine here, and it's affectionately known as 2-PAM. So you all are probably familiar with that. And in reality, you probably even have some available from many years ago when it was delivered from emergency management. Anticholinergics, antihistamines, antipsychotics, tricyclic antidepressants, and then there's plants out there. We're not going to cover all these, but it goes back to the old saying, red as a beet, blind as a bat, mad as a hatter. So they're trying to paint a picture of how this patient will look. So they're going to have tachycardia, dry flushed skin, dilated pupils, and facial flushing. The management here is airway, breathing, and circulation, and then benzodiazepine administration. Hallucinogens, LSD, PCP, and mushrooms, really the thing here is making sure that we are safe. These patients, and especially if we start talking about synthetic marijuana, these patients can become very violent. Make sure that you're protecting yourself and your crew. For the most part, it's more of a scene safety thing for us, and then transporting the patient in. Opioids, I'm not going to cover. You all are probably as versed as I am with dealing with opioids. Basically, it's a respiratory thing, so titrate the effect of your naloxone or Narcan so that you can get the patient at least breathing. You don't necessarily have to wake them up. Your sympathomimetics, so big words, sympathetic is what we're talking about here. So your sympathetic nervous system, and we are mimicking it. That's all we're talking about. That's what your sympathomimetics are, your CNS stimulants. So amphetamines, whether that be just an amphetamine or if it is something like methamphetamine, cocaine, bath salts, caffeine, nicotine, anything that is going to kind of amp that patient up. So they're going to have an increased blood pressure, tachycardia, dilated pupils, altered mental status, paranoia, etc. If it is cocaine overdose induced, one thing, and this may change with your protocol, but it's always been benzodiazepine administration, and really it's always been Valium. But follow your protocol if you ever have a patient that is overdosed on cocaine. Alcohol use disorder, we talked about thiamine a few minutes ago. For the Wernicke's and Korsakoffs, remember that the Korsakoff psychosis is usually considered to be irreversible. So once they have it, it's probably not going to go away. With Wernicke's encephalopathy, that will go away as long as they have proper treatment. But these are both going to be related to alcohol use disorder. I was at my NP job yesterday talking to a patient of mine whose brother is suffering from alcohol use disorder. I'll tell you, alcohol use disorder is very, very difficult to overcome. And the evidence that is out there working from an addiction medicine perspective and in family medicine, the relapse rates and the ability to overcome alcohol is actually harder statistically than it is with your opioids and other medications. So if people have alcohol use disorder, they need support. They need people that can kind of help them through that process. It is a very, very difficult thing to overcome. So nutritional deficiencies, thiamine, most of us don't carry thiamine, but in the hospital, the nutrients and the vitamins and things are what they're going to end up needing. So hypoglycemia is something else that we should be thinking about here. Administer your thiamine with glucose. Your thiamine's 100 milligrams slow IV push, rapid onset, and it may cause hypotension and some other untoward effects as far as like anxiety, diaphoresis, etc. But for the most part, it's a pretty benign medication. It really is just a vitamin that you're giving them. They are prone to other issues. So the falls, right? They have thin blood. So if they fall and they strike their head, they're at a higher risk for having subdural hematoma. There's a lot that goes on with alcohol use disorder. In patients with cirrhosis, Could also have esophageal varices. Remember that if the liver is scarred and it is not draining appropriately, then things start to back up, and the liver veins will back up into the esophagus, and that's where this esophageal varices comes from, and that becomes an airway concern. We have to really pay attention to that. We talked about dystonia with Haldol or Phenergan. We're going to give 25 to 50 milligrams of Benadryl or diphenhydramine. Other things that we can give Benadryl and epinephrine for are wasp and bees, or the other anaphylactic or allergic reaction situations. So anytime you have somebody that has an exposure to a wasp or a bee, try to get the stinger out if you can. Think about Benadryl and then give them epinephrine if it is appropriate to do so. And it shouldn't be because they have just a general allergic reaction to it. We're talking the patient is actually having symptoms of respiratory distress, their throat is closing off. Then think about giving them epinephrine. Obviously, the EpiPen is here, or you can just simply draw up Epi 1 to 1,000 and then administer that. Spiders, scorpions, and ticks. Ticks are really bad right now, so I will mention that. If you're outside in the woods, cutting grass, doing any of that kind of stuff, make sure that you are checking yourself for ticks, because ticks can lead to some pretty dire issue if patients are bitten by ticks and it goes unrecognized. I'm not going to go in too much to the spiders and scorpions, but just know that we do have both black widow, and we also have the brown recluse here in this area. If you're in the northern Kentucky or greater Cincinnati area, if you're watching from somewhere else, I'm not 100% sure where you're at and what you have there, but these things are pretty detrimental. I've told this before, probably in this lecture before, but many years ago, I had a lady that we got contacted for she was ill following a spider bite 2 weeks prior. And to be honest, like the whole way to the scene, I'm kind of grumpy and, it's been 2 weeks. Why are they calling us? And when we got there, she had actually been bitten by a brown recluse 2 weeks prior and was still like deathly ill. Like legitimately, I thought the lady was going to die. And after talking to her, I'm like, how do you know that you were bitten by a brown recluse? She said, because we killed the spider and took it to the hospital. And sure enough, we got to the hospital, and I actually talked to the staff there and said, hey, look her up and see when she was here and what was said. And for those of you that remember Dr. Vest, Joni Vest was an ER physician. She actually had seen her and documented in her chart that the patient did in fact bring the brown recluse in, and Dr. Vest had verified that it was a brown recluse and that she had been bitten by that. So don't underestimate them. Your black widows have neurotoxic effects, and then your brown recluse can have local tissue necrosis, so the tissue around the bite site will start to die off, but it can actually give them symptomatic or systemic symptoms and make them very, very ill. All right, so the brown recluse here, you can kind of see, we always talk about kind of marking the area just so that you know if that area is getting bigger or not. But beyond that, there's really not a whole lot that we're able to do for this. You don't need to do anything heroic or try to put ice on it or anything like that. For the most part, just kind of let it do its thing, transport in, and let the hospital take care of it. As far as scorpions, the sculptured or black scorpion, it's really the only dangerous species to human in the United States. And it's found in the Southwest United States and in Mexico. And there's venom delivered by a stinger on the tail. I never really got into all this stuff. Waldo, if you guys remember Jeff Waldenmayer, some of you's probably had him, is a paramedic instructor. Jeff is very, very well versed in this, and he always studied the toxicology portion. He just was really into that. So he was always pretty fascinating to talk to about like your snake bites and scorpions, so on and so forth. But I just kind of go with the information that's been presented. So Rocky Mountain spotted fever, this is an infectious disease from rabbits and other small mammals via a tick bite. So I told you, make sure that you're checking yourself and your animals, those types of things, for ticks, because they do have not only the Rocky Mountain spotted fever, but they can also lead to Lyme disease, which will end up causing some cranial nerve palsies, lethargy, muscle pain, general malaise. Lyme disease actually is a pretty nasty thing. And it will carry a lot of very unfortunate effects for the patient long term. Tick paralysis is something that you should at least be familiar with because we do have ticks in the area. there is a neurotoxin that is released by salivary glands of the tick. So the patient will become restless and complain of paresthesia in the hands and feet. And paresthesia is like pins and needles, or the tingling. After about 48 hours, they end up with what is known as flaccid paralysis. And here's really the characteristic of this. It starts at the feet and works its way up. So if my feet don't work, and then it starts to move itself up the body, you're probably dealing with a patient that has a tick paralysis. And then eventually the respiratory system becomes depressed once it elevates up to that level from the feet, and that leads to death. For tick removal, if you do have a patient or you have a family member that has a tick, the real recommendation from the American Academy of Family Practice Providers is to grab the tick with tweezers and pull them out with steady pressure, and then clean the area with soap and water. Reptile bites, I'm just not going to get close enough to determine exactly what's going on. Snakes is one thing that I don't necessarily do. But you have pit vipers, and those are your rattlesnakes, cottonmouth, copperhead. They say that they have a vertical and an elliptical pupil and a triangular head. I prefer not to get close enough to be able to determine that, but it's something that at least be familiar with. The reptiles, and depending on the type of venom that it actually injects into the patient, you can have some of the things here. Hemolysis, remember those red blood cells start to break down. Intravascular coagulation, so you get all kinds of different coagulopathies where they're either clotting too much or not clotting at all. They can have a seizure activity, and then acute renal failure. Not a lot that we're able to do, kind of like the spider bites. Airway, breathing, circulation, get IV access. Extremity, you want to immobilize it in a neutral position, because we don't want to allow that toxin to just be releasing freely. So try to just get it neutralized as best you can and not move the extremity. But like the spider that we talked about, you don't necessarily need to use ice packs or put tourniquets on or anything like that. Coral snakes is another one that, from a national registry perspective, they always talk about. So 2 members of coral snakes in the United States, the Arizona and the eastern coral snake. And there's a little rhyme here: red on yellow, kill a fellow; red on black, venom lack. And that is how you can kind of look at the snake and determine if it is venomous or not. So red on yellow, kill a fellow. You can see that this snake here has red and it touches yellow. So this would actually be a venomous snake. If this was red on black, so if the red touched the black without touching the yellow, then venom lack. It is the non-venomous species. And again, I don't necessarily want to get close enough to figure it out. So basically, at the end of the day, snakes and spiders, what you need to know is what kind you're dealing with, whether it's venomous or not. And then it's either going to have neurotoxic effects or it's going to have cardiotoxic effects. So it's either going to affect their neurological system or it's going to affect their cardiovascular system for the most part. Hazardous aquatic life, colincherates or jellyfish, fire coral, all of these basically are treated the same way, and we'll kind of talk about what that is. So signs and symptoms here: they're going to have nausea, vomiting, headache, abdominal pain. There's a lot that goes into the hazardous aquatic life. Really, the only thing that we're able to do is remove anything that we can see visibly. If they have a tentacle, a fragment that is attached or has penetrated the skin, try to remove it. Wash the area with vinegar is what the recommendation is, and then put it in hot water for as long as the pain persists. So the hot water thing, remember that these aquatic life, they are meant to be in a cool or cold water environment. So as soon as you put them in hot water, it really kind of breaks down what the intent of that poison is. So if you can put it in hot water, it will really neutralize the pain and it will quit working. And I have seen this happen firsthand. At the Newport Aquarium, it's been several years ago now, but we got called there for an envenomation. And I was like, okay, immediately thinking snake. And when we got there, it was actually one of the divers that had a stingray put a barb through his hand. And this guy was in really good shape. He was actually military and was there diving and was one of the volunteers. We ended up getting the paperwork, which was written by Dr. Otten, a toxicologist at university. told us what to do for the situation. And really, it was like, it's not really a long-term danger thing. It's more about pain management. So it said get hot water and put hot water on it. So we did. We got like a bucket of beers would come in. And we ended up taking the guy's hand and put it down in the hot water, and he immediately got pain relief from it and started a line, gave him some pain medication, and then transported him over to University Hospital for them to deal with it. So the hot water will definitely help to neutralize the aquatic life envenomations. So they're all basically the same, and for those reasons, I'm going to continue on here. A lot of them here. So here's a stingray, 1,800 injuries per year, 2 inches to 14 feet. So they can be very, very large. They bury themselves in the bottom sand and sting to defend themselves. And actually, I've had an opportunity to go swimming with them. They're really actually very interesting creatures. You just don't want to get the barb to go through your hand or, in the case of Steve Irwin, in your heart. So the stinger is located on the dorsal aspect of the tail, and it's accidentally stepping on the animal, causing a sting to the foot or the leg. Venom will auto-inject into the wound, and the barb may break off in the wound. So in the situation that we had, it just got his hand as he was in the tank with the animal, but it didn't break off. And it really doesn't leave an envenomation. So it's not, it says venom, but it's really not a deadly kind of thing. It's more about just getting the neutralization by giving hot water, and then the pain will go away. So signs and symptoms here: localized, immediate, and intense pain. And it was for that individual. Localized edema, variable bleeding, and then tissue necrosis. It can occur. And then systemic. So what's going to happen throughout the body. Depends on the animal and what is going on. So with the stingray, none of these things really, other than pain. But obviously with some of the other stings that you may end up having or envenomations, all of these things may be present as well. The management: airway, breathing, circulation, put them on a monitor, check their vital signs like we would normally do in all of our BLS patients. Irrigate the wound with normal saline or tap water. Remove the barb if it is visible in this situation here, immersed in hot water, and then give them analgesics. And that's exactly what we did. And in that situation, as I told you, that they're already pre-planned by Dr. Otten. He knows every animal and the species that are down there and what you should do in the event that you have an interaction or an account with one of them. So they have laminated cards. And we showed up, they handed us a laminated card. It was literally like, okay, give me a few seconds to read this. I read it. It was like neurotoxic effects, none. Cardiotoxic effects, none. Signs and symptoms, pain. So once we knew that that's what we were dealing with, we literally just followed the instructions. So if you do ever happen to make a run down there, and we have had a few, there was a shark bite there. You don't ever think about making a shark bite in northern Kentucky, but that has in fact happened. So it does happen occasionally where there will be a call for service down there, and it's normally a pretty interesting thing because of what the creatures are that they house.